Thank you, Raja, for your kind introduction. Sclera is mainly composed of collagen fibers, and causes of scleral fibers have been studied mainly histologically, while their precise in vivo arrangement remains a challenge. And polarization-sensitive OCT, or PSOCT, has the capability to visualize the density and orientation of fibers by measuring birefringence. Birefringence occurs when a material exhibits two different refractive indices depending on the polarization of light. And recent studies have shown complex collagen structures with PSOCT within a limited area around the optic nerve. So the purpose of this study that we used PSOCT to visualize the direction of scleral fibers in the wide area of posterior fundus of highly myopic eyes, whose sclera is easily visible. And we then investigated dome-shaped macula as a scleral pathology. And I show you an example of highly myopic eyes without pathologic myopia. In highly myopic eyes without pathologic myopia, only inner sclera is seen with OCT. And these are PSOCT images. The top panel shows birefringence, which means density of fibers. And green shows low density, and yellow shows high density. In highly myopic eyes, actually, mixture of different densities is seen. And the bottom figure shows the optic axis, which is the direction of fibers. And direction is color-coded, blue for horizontal, yellow for vertical, and pink-green for oblique. And in this horizontal image, you can see horizontal blue fibers running from the optic nerve toward the periphery. And in a vertical section, you can see horizontal fibers in the macula alongside oblique fibers upper and lower to the macula. And to our intuitive visualization, this is a streamlined image. And you can see circular arrangement of scleral fibers around the optic nerve, and then inner scleral fibers radially run to the periphery. So from when we see the scleral fibers from inside, there is a circular arrangement, and the inner scleral fibers run radially to this periphery. And then to observe the outer sclera, we examined eyes with pathologic myopia, because in this case, we can see the entire thickness of sclera. And this is, again, upper panel is birefringence, and lower panel is optic axis. And in density, in a vertical scan, you can see low density in the inner sclera and high density in the outer sclera. And the optic axis image, inner sclera is thinned, maybe because of the choroidal thinning, but the thin horizontal fibers run from the optic nerve toward the periphery. And so when we see the scleral fibers from outside the eye, scleral fibers run vertically. So this is an illustration. Around the optic nerve, we can see a circular arrangement of scleral fibers. And inner fibers run radially to the periphery. And outer retinal fibers run perpendicularly, almost vertically. And in eyes with pathologic myopia, inner scleral fibers get thinned, while outer scleral fibers remain almost unchanged. So let's dive to a dome-shaped macula. This is a horizontal dome, so you can see a dome-shaped macula only in vertical section. And this is PSOCT image, and this is vertical scan. In birefringence image, you can see a low density of scleral fiber is aggregated in the dome area. And in the optic axis image, you can see the aggregation of horizontally running inner scleral fibers, while outer scleral fibers do not seem affected much. And in a magnified image, you can see a dome-shaped elevation is composed of aggregation of inner scleral fibers alone, and the outer sclera is not thickened and rather compressed by the aggregation of inner fibers. So in dome-shaped macula, for unknown reasons, horizontally running inner fibers remain across the macula and aggregated there, while other inner scleral fibers thinned. So then bidirectional dome. In this case, both in horizontal and vertical images, you can see dome-shaped macula. And the images are similar. In birefringence, dome area is not a tight aggregation. It's a loose, low-density inner fibers aggregation. And in the optic axis image, you can see outside the macula, you can only see vertical outer scleral fibers. But in the dome, you can see a mixture of inner scleral, horizontal, and oblique fibers. So this is horizontal scan. So again, in bidirectional dome as well, inner scleral fibers strangely remain only across the macula, and it develops the dome-shaped elevation. So it is inner scleral fibers and not outer scleral fibers which cause irregularities of scleral curvature. So this is again a streamlined image to seen from the inside. You can see that in dome-shaped macula area, a mixture of inner scleral fibers are seen. And actually, in normal eyes, sometimes we see horizontal inner scleral fibers tend to remain in the macula. So macula is an important part for the vision. So sclera has some methods to protect the macula. So inner scleral fibers tend to remain. But this is a good thing, but it causes susceptibility to dome-shaped macula. So in summary, PSOCT clearly visualized the cause of scleral fibers in myopic eyes. In dome-shaped macula, its inner scleral fibers tend to aggregate, while outer fibers are not thickened. And when horizontal fibers predominantly aggregate, it causes horizontal dome. And when oblique fibers also aggregate, it causes bidirectional dome. And visualizing, and with usual OCT, we can only detect the thickness and the curvature of sclera. But visualizing scleral collagen fibers and visualize what is happening in the sclera could enhance comprehension of pathophysiology occurring in the sclera, like dome-shaped macula. And the next target is staphylomas and pachychoroid spectrum diseases. Thank you very much for your attention.
Kyoko, I think this is very interesting in terms of understanding collagen, scleral collagen fiber direction. So has any people working on the pathology changes on the scleral, I mean in the highly myopia eye?
Yes.
So, so is it because of the collagen, type of collagen? Because we understand collagen type 1 and collagen type 3, they're different. Collagen type 1 is for rigidity, and then collagen type 3 is for elastic. So would this pathology changes on the collagen type is associated with the direction of the fiber?
Yeah, actually at this point I didn't differentiate collagen 1 and collagen 2, but what we can say now is maybe inner sclera and outer sclera may have different roles physiologically and pathologically. And outer sclera is like a last resort to protect the eye from the eye rupture. So outer sclera remains until very, very severe conditions. But inner sclera may gather somewhere and may thin other places. So it causes eventually irregularity. So I think it may be the inner sclera which causes staphyloma edge, dome-shaped macula, such elevation. So yeah, outer, the role may be different. But collagen type, I haven't checked it yet. So the correlation between orientation and quality of collagen types would be very important topics. And in highly myopic eyes, it's inner sclera which thins, and outer sclera is almost unaffected.
Okay, thank you.
Thank you, Professor Kyoko. Can I ask a question? It is a phenomenal work. Congratulations, and always very inspiring. I found that all these imaging, do you have some index or quantifiable measurement so that we can interpret more easily? Otherwise, by doing the pattern, sometimes it may be difficult to interpret.
Yeah, Thank you very much for your great question. Yes, quantification is really necessary. And we can now measure the thickness of inner sclera and outer sclera and check a correlation with myopic degree. And, density is a little difficult to measure, but quantification, I think, is a key. And we now have many treatments like red light therapy, and we also measure the scleral quality, direction and density before and after red light therapy. And if this therapy affects the scleral quality, I think the effect may be permanent. So quantification is a key. Thank you.
Great talk. A couple of questions. First one is the PSOCT. Can it also be used in low myopes to detect the sclera?
Yes, still to visualize the sclera, we need to see the sclera with conventional OCT. So at this point, for example, pachychorus spectrum diseases in emmetropic eyes, hyperopic eyes, it's impossible, not yet. But if the resolution and penetration improves in the future, it may become possible.
The other question is, do you think you will see such differences even in the anterior region of the sclera if you believe in the global expansion model of the eye?
Yes, yes, it's possible. But to visualize anterior sclera, we need a different device. So our device is not equipped with such quality. But that is an important point. Thank you so much.
If I can have one last question. Once again, excellent presentation. You had mentioned about the density being less in the horizontal layers, fibers, and the subfoveal, but still the sclera was thicker compared to the extraocular sclera. So did you also see the number of posterior ciliary arteries penetrating the sclera? Was it less or more in the thicker outer sclera versus thinner outer sclera?
Yeah, that's a great point. Thank you so much. Actually, with this device, we also found that at the penetration site of ciliary arteries, there are circular arrangement of sclera because the penetration site is fragile. And in highly myopic eyes with expansion of globe, the emissaries enlarge, but eyes almost never spontaneously rupture. So like the optic nerve area, a circular arrangement there. So I think this can resist to the axial eye expansion and maybe scleral thickness. But we haven't examined that, but that is a great point.
Thank you so much, Dr.